So, and Anna, did we go over the rib innermost intercostals with you as well?
I'd really love to, because my ribs keep going out.
Let's start here at the rib pain. And with this EDS and rib pain is a really common thing. And often what happens is there's a feeling of tender ribs or even a feeling of air hunger. So usually the heart and lungs are totally normal. And any of those posterior joints at the costovertebral area, so where the rib and the vertebra meet, can be sore. So that's really common just because there's too much movement there. And I think the comment I made last time was that there's a lot of, I had clients who I would say, oh, your rib is not positioned properly, your ribs moved, and they'll go to their doctor and say, well, my physical therapist said my ribs are positioned. And not like that. But they do. So, and they do move anyway, and they can get dysfunctional. So one of the things that I wanted to remind people about is the layers of muscles between the ribs that work with the diaphragm, right? Those are mainly the intercostals, and that we have 3 layers of them, which I'll show you in a minute. Also, the other thing to consider here is there's a lot of coordination going on with breath and with movement. So the ribs have to move a lot, and they have to move in a coordinated way to keep everything working properly. And if one side goes more than the other, or if you're in a rotation and then you take a deep breath, that can put uneven pressure into one side versus the other and can potentially cause any sort of subluxation. So we could have it, if we could have it at the costotransverse junction in the back, or we could have it in the sternocostal articulation in the front. So these were, and this is a duplicate. I'll show you the other one, but here was my intercostals. Give me just a second and I'll switch over and show you the other pictures, because I can manipulate those as well. And oh my gosh, I don't want this. Oh my gosh. Okay, skip, continue, randomly generated skin. Okay. All right, so here we have the intercostals, and you can see we have the external here, and I peeled away the external, and that way you can see the internal here. So opposite fiber directions, really, almost opposite here. So those are layered one on top of the other. And the one that, and I'll show you what that looks like in rotation if I can. So in rotation, right, we can see it all in the back as well. Yeah, so our internal are now here and our external are now, our internal are now on this side and our external are now on this side. So that would be these 2 layers. Then if I go, there's one more layer and it's actually inside. I'll see if we can see it from here. That's the diaphragm we can see there. And you can see like what a role that diaphragm plays in against those ribs if I rotate around. And so it can definitely upset the motion of the joints lower here and then in the back over here up till about, I would say up till about the lower ribs down in here where the diaphragm would be coming up that high. And then if we go back to the other one, we can look at the innermost intercostals. And there you can see them, just another layer way down in here, deeper than both of those layers, a little further on the outside here, connecting all those ribs together. So actually 3 layers of muscle on those ribs holding. And then we have little muscles along. Yes.
So Zeina, you're saying from innermost to internal and externals on the top.
Exactly.
Okay.
Perfect.
So the external.
Yep.
Okay.
Yep. And then here we can actually look at the other things going on here. So then we have our levator costorum, and look where they're attaching to our processes above, and same level and one above. So we've got two levels of those that are attaching to the vertebra to lift up the rib. So in somebody who's really mobile, who knows if the muscle is going to pull the rib up or muscle is going to pull the vertebra, right? We don't ever know with somebody who's mobile. The goal is that the rib gets pulled up by this connection. But if something's really unstable in this area, who knows where this is actually getting pulled. If we're in a different motion too, like a rotation or something else where we're not exactly straight, perhaps that could be an issue as well for somebody who's hypermobile. So anyway, just to give you this idea that there's so much going on here. And the other thing I was showing last time was that the ribs, remembering that the ribs have several points of attachment onto the vertebra. So if I go like this and zoom in here, you can see that the rib is attaching not just in one place, it's on the body, it's on this close proximal process, and it's here as well as we go. And it actually reaches, I believe, to the one below, the vertebral body below, and then the transverse process above as it's coming out. So it's got this articulation, long articulation, or several articulation points as we go through. Let's see what we can see from the back here. There, you can kind of see those articulation points. Oops, that way as well. Yeah. So just remembering that it's not just one area, but if this transverse process was to move or the vertebra was to turn, that would also upset this just as much as if the rib itself was the thing that moved, right? Great, let me go back to this. All right. So the exercises that were recommended, that I found recommended for this, were the ones actually you and I talked about, laying supine with a book or sandbag over the belly and just breathing for about 20 minutes, moving that weight up and down gently. So it doesn't have to be a big motion. The idea is that weight is going to give you some grounding and allow the ribs to coordinate themselves, figure out what they're supposed to do. And then the other was to lay with a ball under the belly. This one says 1.5 inches, which is really a small ball. I find that might be really intense. So sometimes a bigger ball is a little bit better first, and then see how that works, and then moving to a smaller ball. But then same thing, breathing with that ball underneath to help the ribs find their coordination, release any tension as you're breathing. Other interesting thing would be singing using the high and the low notes, or using a recorder or wind instrument. So that can really actually help the rib and lower back pain and strengthen all the muscles of breath around in a balanced way. Yeah, go ahead, question.
About because I do this every day with the supine and prone, but I use our typical blue ball, the squishy, bigger ball that we did it with. And
yeah.
That's quite a small ball. Why is that more useful than a more, because I find that bigger ball almost helps my QL and my hip flexors in the front melt a little bit, because they are kind of at the edges of where that bigger ball is, which would not be the case with this ball.
Yeah, I'm not sure why this was recommended. I'm not sure that I love the recommendation of it being so small. I think it was more to be able to get a little deeper in there. If you would put the smaller ball there, it's going to get a little deeper with your body weight. And so it's pulling on the fascia as much as it's pulling like directly. You don't want it on your ribs particularly. So I think you might get more of a fascial release with this than you will with the bigger ball, but I think the bigger ball is really just more comfortable and still I think is going to work towards that coordination and motion. But yeah, so it would be interesting to see what people's perception is, or have a bigger population of people who are doing it and ask why this specifically. Yeah, great. So if we move on to arm pain with EDS, we're talking about shoulder subluxation and or dislocations, right? That is very, very common. Thoracic outlet syndrome, super common as well, that tension, nerve tension in the front. Tendinitis, elbow, tendinitis, bursitis, subluxation of that radial head can happen. Wrist and finger subluxation, lots of muscle pain and tendinitis in the wrist and fingers. And then a lot of times the laxity of the shoulder can cause overuse of those rotator cuff muscles, because they're the ones doing the extra work that the ligaments in the capsule are not doing. So they sometimes overwork and end up in spasm, and that could also be very painful. If we go into hands, we had a nice little discussion about hands. There's a lot of times there's this over gripping of a pen or pencil and pushing down hard with writing that happens because to try and find some stability over the pencil or pen. There's also less proprioception in the hand and less feedback. So also I would say my personal experience has been that I actually ended up having problems in PT school. I could only write with a pencil, take notes with a pencil, because it was the only thing that provided enough friction. But I had small regular pencils because I liked those the best. They were the thickest straight and they provide the most friction, not the mechanical pencils. But I ended up with super hypermobile fingers, thumbs at many joints of them. And I ended up, we also do, when you learn in PT school, the Maitland technique we were doing, I had to do mobilizations with my thumbs straight down into somebody's spine, along their spine. And my thumbs, as soon as they got pressure, they would fold one way or the other way. I could not hold because there's no end point for my thumb, like most people have. And so that combination with the pencil ended me up not being able to pass my clinical rotation. One of my clinical rotations, they said they wouldn't pass me unless I dealt with my thumbs first. And they sent me to hand therapy to get splints so I could actually do the manipulation. Like, this is PT school. So instead of thinking, well, this is not going to work for this body, which is later what happened is I just changed the mode that I did that. I don't do that with my thumbs. And I actually was able to write with the pencil between my knuckles instead of using my thumb at all. And but I still prefer grippy. And I was talking about how I have a pencil for the iPad, but I can't really write with it because it's too slippery and the pencil's too thin. So it's very hard for me to write with that pencil. So, but I ended up with this tendinitis issue because of the amount of pressure I had to put on there to create friction on the page. So anyway, it can be a pretty difficult task, but there are other ways, and fatter pens and pencils that really help. Things with like felt tip pens are helpful, thin felt tip pens. I ended up writing with Sharpies a lot and pencil. That was really the things that happened. Then I just put these big fat things on them, or hold with knuckles instead of the finger, the thumb. So if we pop down to legs and stability, I usually start with the feet and ankles and try and stabilize up the chain, because if those aren't going to hold them at all, then are we going to be able to hold up the rest of the chain? Usually somebody who's hypermobile has flat feet. It's general, not everybody, but a lot of people do. And when they take that's with weight on it, but if they lift up the foot, there looks like there's an arch in it. Then they put down the foot and it totally flattens out. So that's very common. The other thing to look for is a hypermobile patella. So that's really common as well, that it can slide in and out of position. There's also sometimes pain in the lower leg that can be from the tib-fib joint. And so that's not that common, except in, it's like the radial head. And so the tib-fib joint is this one here. And that sometimes can get too loose for people who have EDS or hypermobile. Instead of just staying put, normally it only just rotates a very tiny bit. But if it gets too loose, it just kind of moves a little too much forward or backward. And that can be really painful. It can also pinch that common peroneal nerve, which wraps right around this fibular head, basically all the nerves to the lower leg, front, side, and back. So that could be really painful and also get some nerve symptoms down into the foot. And so that would be what the cause of a foot drop would be. And then somebody could trip on their foot, stumble on their toes.
What's a hypermobile look like?
Say that again. It's a hypermobile.
What's a hypermobile patella look like when you're looking at it? Is there a way that you would see that?
Yeah, it will really just, what we do is we have the legs straight out and relaxed. And then if you look at everybody's knee and the leg is straight out and relaxed, you can push your kneecap around side to side, up and down a little bit, and you can kind of dip it down one, if you push on one. Oh, I did that last time too. If you push on one side, your leg won't come off, I promise. I lost a leg.
So it goes
Terrible.
up and down and it tips a little right to left like that.
Tips right and left, and point and top. So it should move around some, but somebody who's hypermobile, that kneecap just doesn't really feel like it has any limits.
Okay.
And so
Really see
it
that when
happens.
you're walking, it would be moving around or anything.
Where you notice it is in bending to straightening. Where you notice it is bending to straightening. Sometimes the kneecap will get stuck and out of its groove, and the knee won't want to straighten, and or may not want to bend. But more typically, I've seen it that it gets stuck in a little flexion because the kneecap's not in the right place, and then it has to pop back in and then slide. So and people notice when that's what's happening, so they will tell you.
Okay.
It's not an incognito thing. It's a really very apparent feeling of something being very wrong for a moment because they get really stuck. So,
and different than some client was telling me that they had been diagnosed with hypermobile meniscus.
Oh, I haven't heard
I've
of that.
never heard of, and I said, I don't know what that would be. I've never heard of that before. And I started laughing because it was like, it just seems like a really, I don't know that exists.
Yeah, I don't know what that could be either.
Well, I would think you would know if it existed. I thought maybe they just kind of made that up. Hypermobile meniscus.
Or maybe, yeah, I don't know if it's a thing.
Anyway, I decided to share that because I found that really, like, I've never heard of that.
I'll have to look and see if that exists because I don't know it. Yeah, I haven't either.
Super bizarre.
So,
anyway.
Yeah. So fibula too much motion or patella too much motion, both of them are quite uncomfortable. So then SI joint pain, super common also, too much movement there. Remember, that's all pretty much ligamentous, holding that SI joint together. Pain could be lower back, could be buttocks area, could also be groin, can be into the leg, but not usually. Usually, I can spell that better. Oops. And then the pelvis can rotate anterior or posterior. It can also go out flare or in flare, right? So it can go out a little bit on one or be too much in on the other. And then usually the most discomfort is when there's a leg length discrepancy, a functional one, meaning the bones aren't different lengths, but the pelvis is shifting so that the legs seem different lengths. And so that it's usually an anterior posterior rotation that will take, or an upslip that will take the leg, one leg longer than the other. With
my pelvis, with my shortness on the left, is that partially that's anterior on the right and upslip on the left? My left side is short.
It could. I think in your case, that's what's happening because your QL is pulling up on the left.
Yeah, it's shorter on the left.
Yeah, so it could be, there's a few things that can happen in that case. So it's not always that it's an upslip if the QL is short on one side. If the QL shortens on the back on one side, it could rotate that pelvis anterior also,
Okay.
right?
So
So
upslip
it just,
straight up, but it could shorten because it's anterior.
so if it shortens in the back, it goes anterior, which means the leg ends up longer. But
Okay.
if the QL pulls up in the back and the leg is shorter, psoas may also be pulling up in the front, and that together can pull the leg up, or something else in the front could help pull that leg up instead of into rotation.
Okay. So if you're getting a pull from both sides, so as in QL,
yes,
upslip, but if you've got one or the other, you have the
a tilt.
here. Okay. So
Yes,
that's great. I mean, it's not
yeah.
great.
It's not, yeah, it's not great, but it's great to understand that, yeah, there can be differences. Okay, and then we talked about POTS, which is postural orthostatic tachycardia syndrome, or also known as dysautonomia. So basically, it's a dysfunction of the nervous system and can be due to autoimmune issues. What the people are feeling, right? They're fainting, they're having fainting spells or dizziness, palpitations, sometimes a headache with standing. They have a lot of times difficulty maintaining their body temperature, either hot or cold. There could be some brain fog, some anxiety, and some stomach pain, usually some non-restorative sleep. So exercise has been shown to really decrease the symptoms of POTS. The problem is that people sometimes have a hard time staying upright, because when they get upright, they get this, the heart rate increases quickly. So all these symptoms come on when they're upright. So that's why there's that point about they can exercise in a reclined or supine position and then move upright, more and more upright as they get better. So the recommendation is endurance exercise for 30 minutes, 3 times a week. So we can exercise them laying down on the reformer, which is great. And if our goal would be 30 minutes of endurance exercise 3 times a week, then you want to think about exercises that really just keep them moving. So footwork, bottom lift, yeah, go ahead.
So I'm sorry, this is really kind of rocking my world a little bit. So I not to talk about myself too much, but I I've had all these fainting spells where I've passed out,
Yes.
really hurt myself. And I went to a cardiologist and they said I had vasovalgus, which is basically just saying that when I get up, it doesn't equalize itself the right way. But this sounds much fainting, dizziness. I get really cold, difficulty, like I get cold, like my teeth are chattering.
Mm-hmm.
And that
Yeah, so this,
my heart.
I think there are 2 different things we could talk about. So the orthostatic more hypotension, which would be that your blood doesn't get up to your brain fast enough, and then you can pass out from that. So that is a possibility of something that could happen. And that could be, I don't know if it's more prevalent in people with EDS. Actually, I haven't seen, I have to look and see if that's true, but that would be because your muscle pump and everything's not pushing the blood back through the venous system enough to get to your head fast enough, or your heart's not pumping it out fast enough through the vessels to get to your head when you come to stand up. This is an increase in heart rate. So it's a big jump in heart rate. I think I have the,
okay.
Yes. So here we have this, in adults, it's a heart rate increase by 30 beats within 10 minutes of standing. And in kids, it's a heart rate increase of 40 beats per minute. Then we would call it POTS.
Okay,
so
because they did this test where they have you lay down and then they sit you up and stand you up. So they would have known the difference between this
the 2
and the blood.
Mm-hmm.
Okay.
Yeah.
Okay, great.
So this would be a little bit different. This one, the difference is after, I think with orthostatic hypotension, you can correct me if I'm wrong, but the difference is after you're up for a bit, you feel fine. It goes away and gets better. Here, what happens is the heart rate comes up a little bit after you've been standing and stays up and then causes those symptoms. So they have to go back down. They can't stay upright because the heart rate's too much. So that's why they're saying that exercise laying down. And then there's this whole Dallas protocol, which I think I've referenced in the references, if you want to look at the whole protocol, but to working their way up to exercising upright that you could work on. But for our purposes, if somebody were to have this issue, you could keep them lying down and exercise them. There's so many options of things we could do, supine. So that would be really nice for this client. And then we can talk about mast cell activation. So mast cells are, we talked a little bit with Lynn about this, but they're a blood defense or immune response. And in EDS, mast cells get triggered, and they really don't know why that happens. We just know that it's a common issue with EDS. And what happens is there's a release of like 200 chemicals all at once, which are what are called cytokines and histamines. And that makes your body trigger this immune response. And what you see is rash, hives, fatigue, bone and joint pain, abdominal pain, nausea, palpitations, flushing, especially after the shower, is really common, and or feeling of having like the flu. So much of that diagnosis is clinical. They're looking for these symptoms happening to diagnose it. They could do an endoscopy and look at the number of mast cells if they were looking specifically for that to see. But what's really interesting is that Lynn was talking about this is, and it's happened for more, it's commonly a treatment, is to have them take an allergy histamine reducer allergy pill every day. And when they do that, these symptoms go away. And it's amazing how much better they feel. Lynn said that she didn't have the pain, so much pain. Her pain went down, her sensitivity to hot, the flushing after shower, all of that kind of went, her insensitivity to hot, I should say, is what she had. All of that normalized a lot just by taking, I think she's just taking Allegra once a day. So it's really easy to diagnose by clinically diagnosed. So I don't think a lot of people are doing the endoscopy unless they happen to be doing one and want to check, probably, unless it's super severe and they need to really see. Yeah, go ahead.
How often, like, for example, I've been in the emergency room with rashes and hives all over my body, which were unexplained. Now, maybe this is what was going on. Like there was no at the time, like, oh, did you do this or that thing? So, and I get them occasionally, hives. So, and I never thought of this. Would it be something that happens pretty regularly, or would it be more random?
I think it can be random depending on the state the body's in. So, and I think for some people it's a constant thing, and for some people there's certain triggers. Yeah, so I think it definitely could be part of it. You're definitely more susceptible to that happening. Anybody's susceptible to this happening when you're exposed, but I think it's just that it tends to be much more common for people with EDS or high-end hypermobility issues.
It's just so all these little things that, like, I know when Lynn was talking about it, I've just now remembered, like, being in the emergency room, and they kept asking me like what I was exposed to, and we couldn't ever figure out. It was just like, oh, well, just this random thing happened. You're in the emergency room, but like, so it's just hitting me now.
Yeah.
Hey, can you guys hear me?
Yes.
I have a reception just going all over the house. I'm outside my home. Diagnosed.
Sorry, again. Can you? Sorry, Lena. I couldn't. It was breaking up as you were talking.
Yeah, you probably won't hear it.
I got you now. Oh, say that again.
Oh, okay. Has Anna been diagnosed with Elhers Danlos? That's my question.
No, not you haven't, right, Anna? Did we lose you?
She's there. She's there.
Oh, can you hear me now?
Yes, we can hear you now.
Sorry.
Yes.
Just that I don't think you may know better than me, Zeina, because you know my body and you know the stuff that don't have all of the things
Mhm.
that would make
Yeah.
it the so.
I mean, you're definitely on the hypermobility spectrum. And I would say that I would assume, yes, that you have EDS. The only way that anybody could super confirm that would be the genetic testing and looking for those genes. So I couldn't say per se just by clinical, but clinically, if I were allowed to diagnose as a physical therapist, which I'm not, I would say that you do fit the protocol. Your score would be high enough based on your knees and your elbows and your forward bend. And
Right.
we are on you and your age, you're really in that group for diagnosis, and you have enough of the other symptoms that on paper you would qualify with your scores. And then to fully diagnose, though, they say that you need the genetic test to see.
But I would be lower on the spectrum score than say you or Lynn or Andrea is what I'm.
Yeah, I mean, definitely than Lynn. I think Lynn is really the extreme. Andrea is very close to Lynn. And I really have it as a way of life, I think, more than an issue. So most of the time, I basically have a way of life of being hypermobile that hasn't really interfered.
Right.
Maybe being a physical therapist has helped me because I do, if I think about it, I do a lot of fixing of myself. Like Sunday, my knee dislocated again, and I just put it back in and life goes along. And like, I think so maybe it's more than what I take it to be, but for me, it's just, I run, I ice skate, I rock climb, like I don't have any issues.
Right.
Really, just some loose joints and some tendonitis here and there that I work through. So
just hearing like Andrea say, "Oh, I'm lucky if I can hold the tabletop once a week," kind of put it in
yes,
perspective of like, I really don't have anything to complain about. That my rib is out a little bit here and there. You know what I mean?
Yeah. So I mean, I think the difference between you and I and Andrea and Lynn is both of them had an incident which made them stop doing entirely. Now, granted, you've had some situations where you've had to stop, and I've had a few, not as many as you have, where I've had to stop for a little bit, but I've been able to just pick up and get going again. I would say it probably takes me longer to rehab, and it takes me more work to maintain than an average person. That I would say. So I think on that, for me, on that hypermobility, I'm on that hypermobility spectrum. I don't see myself where they are, and I don't know if it's just luck, or if that I've been able to maintain my strength, and the fact that I fix myself, or that it's just that I'm actually not as extreme. I think also that for sure.
Right.
So
this is interesting.
Yeah.
Did you hear any of that, Lane?
Yes, I did. Yes, I did.
Oh, good. Great.
Poor thing, Lane. It's just an awful situation
It's a
today.
really hard day today.
I'm sorry. All right. So then, I'm on the wrong computer. Hold on. So if treatment in here, we already sort of talked about the allergy meds. Other causes that can be, would be a change in temperature. So changing your temperature around you, ambient temperature can cause a flare. Rubbing on the skin, physical exertion. I knew somebody who couldn't exercise because sweating made her flare entirely. Direct exposure to the sun could be a trigger. Other triggers are things that are other triggers for not just people with EDS, right? Alcohol, narcotics, sudden temperature, already say a low histamine diet, NSAIDs. So it's not really recommended that people who are hypermobile take non-steroidal anti-inflammatories. And then a lot of inactive ingredients in pills. So it's good to watch what's actually in those pills. And then hidden sources in foods, dairy, seasoning, eggs, gluten, beef products, or I should have said meat products except for lamb, and poultry, venison, I didn't change that yet, and poultry. And poultry is not spelled right either, oh my goodness. All right, so things that you can do to prevent it would be filters, HEPA filters, which most people in California now have, or Northern California at least, or yeah, Southern too. Pollen guards, mask wearing, avoiding long baths or showers, avoiding rapid changes in temperature, avoiding wool, dust, and cigarette smoke. So abdominal pain and EDS is also super common. People tend to have slow intestines, or can have sort of that alternating diarrhea and constipation, which is kind of those IBS symptoms. So both POTS and mast cell activation syndrome can cause bloating, nausea, acid reflux, and constipation. Also, things that can cause discomfort or that are common are prolapse for women. So that could be a cause of discomfort as well. Something that can help is what's called the low FODMAPs diet. There are a few good on the internet. Is a great resource to look into that if you think that would be helpful to you or one of your clients. So looking up that diet online, there's lots of resources about it too, just to keep your body at its best, to keep all these symptoms away. And then the other things, you could have what's called median accruate ligament syndrome. So long accruate ligament in there, which is basically what holds, I believe, what holds up or connects your diaphragm to the lower abdomen. So, and then you can have problems with the celiac artery, which is the blood to the intestines. It sticks out from the median accruate ligament and can compress or hit the celiac ganglion, which is a nerve again, causing compression or pain. So also common pelvis pain and bladder pain in EDS. So pelvic pain is usually worse during the menstrual cycle, we know, because of hormones. So a lot of my clients have chosen to go on birth control to stop their periods, which basically will stop that cycle of laxity every month, to help give them a little more stability. And it really seems to help actually when they do that. And it also, if we can, pelvis pain can also cause mast cell activation. So going on to the hormone can really help that stabilize that as well. Pelvis pain can also trigger the POTS again. Bladder pain or interstitial cystitis could happen. So inflammation there, we don't know why. We don't know if it's related to mast cell activation. Can also be treated with medications. And then vaginal pain could also be a mast cell activation or irritation. Sometimes a Benadryl cream or a chromodynamic cream can help with that as well. So in children, what you see are lots of dislocated joints. Sometimes they complain of body-wide pain. They bruise easily. They could have abdominal pain and fatigue or any unidentified bleeding. And the recommendation that I found for this was really that you find a doctor who knows about EDS to take a child to, or to send a child to, because otherwise they can look like there's been some child abuse, because they might bruise, they have pain, their joints are dislocating. So if the physician isn't aware of EDS, that could be a bad scene for the parents and the child, really. So making sure that if you suspect that there are doctors, or telling them specifically to look for a doctor who knows about EDS and can treat it. So pain management, it varies based on the client. Most of the time, what's happening is there's micro trauma. It's much more common. Tissue repair is harder. It takes longer. And when you get an injury, there tends to be more trauma than you would expect. And so also the trauma could be much more obvious. What do we do about all that? Basically, try and stabilize everything, right? Stabilize the joint, then strengthen it, then retrain for proprioception. And what's super important is to teach the just right amount of work instead of overusing muscles. So what I find, and actually Andrea could talk to this point, is that she would try and work so hard to feel connected that she dislocated ribs by trying so hard to tighten her abdominals. Because they're looking, when you feel that loose, as some of you know, you're looking for stability in your body. But working so hard for that stability actually ends up moving the joints rather than creating stability. So it's also a problem with trying to stretch muscles, right? So stretching tight muscles can be dangerous because sometimes it's not the muscle that gets stretched, it's the joint that gets out of alignment before the muscle will even stretch. So depending on the strength of the muscle and the tightness of the muscle, you have to be really careful about how you're stretching them so that there's not a joint that gets to be in trouble as a result, right? So some of the things, and I didn't know about this till I did research actually for this project, that they actually now make skin tight clothing that has the tape lines of kinesio tape sewn into it. So the idea is that if you use that tight clothing with those tape lines in it, it helps find the activation of the muscles or helps the body feel like it's being held together. The other thing that can be really helpful is exercising in water. It provides, the water pushes on the skin and gives some proprioceptive feedback, which usually feels really good to the person, and they have less body weight to carry. So that's also usually really nice.
Hey, Zeina,
Yeah.
you hear me? The curious thing for me of the last slides is what if the children is generalized pain all over, and on this last slide, the micro trauma. So I'm thinking, do kids just move too far because they can? Do they get, is the pain instant feedback, or is the pain felt out?
Yep. Did we lose you, Lane? So I think I got all your question. I'm going to jump to it. So with the kids, if you look at kids that are hypermobile, what you see is that they're constantly hanging on their joints, right? And I think that that's easily causing micro trauma. Plus, their joints are moving in and out of position a lot, so it's causing movement back and forth on the joints, on the tissues. So it's easy for those little traumas to happen. So I think there's just this constant trauma and probably inflammation and trying to repair beyond what other kids experience, like getting stronger. If a kid does a lot, like runs a lot farther or jumps down from a high tower, they're going to have sore muscles. But in kids who are hypermobile, it goes beyond, it just goes a step beyond. So they're usually more sore, maybe their joints hyperextending more often, causing just this constant amount of trauma to the muscles and the soft tissues around. That would be my understanding. I just picture a little kid hanging from a monkey bar who's hypermobile. I mean, look at that arm versus a kid who's strong, holding himself up, hanging from a monkey bar. Yeah, really different. So here again, just touching on that kinesio tape built into compression clothing to help with joint position sense. We want to find muscle strength without stressing the joints. So in a proper range of motion, not at the end of the range of motion. So really working to keep neutral range of motion in the strengthening process. And you want to start slow with low loads and then progress slowly from there to heavier loads. Avoiding extreme stretching through activity.
Zeina,
Oh,
Lane just texted me that she got it.
okay, awesome. And then exercising in water might be the best. Swimming might not be the best because swimming might be too unstable, too many parts moving, whereas exercising in water gives that feedback feeling. But I do have some EDS clients who are swimming and feeling good about it. So I don't stop them if they like it. If I'm starting somebody in the water, I probably wouldn't start with swimming. It's a lot of moving parts. Taping for EDS, you could use some kinesiotaping that might help with proprioception, might help the muscles relax, might help stabilize the joints, might help reduce swelling. And I do use some firmer tape sometimes, but I'm really careful when I use firm tape with people with EDS because sometimes they can't tolerate it. You have to be careful about how tight that tape is and where exactly you've placed it. So sometimes they love it, or they usually what happens is they love it at first, and then an hour later they've got to take it off because it's just pulling too much on them. Whereas a kinesio tape tends to last, they'll be able to tolerate it a little bit longer. Sensitive skin, a lot of people with EDS have sensitive skin. You can use a cream spray or milk of magnesia on the skin, which actually first, that will protect the skin, and actually the tapes usually still stick. So that's a good thing to know about. And then the recommendation from some doctors is to use the Feldenkrais method for joint position sense, just because it's so gentle and it gives them an internal awareness of the joint position sense. And then Pilates with the emphasis on joint positioning, right? So making sure that their joints are in good alignment and that they're not hyperextending or going to full hyperextension range of motion with weight loads through them. So now there are some things that might help with EDS, but there really is no treatment for it. So there is an antibody treatment that's for migraines that might work to help a little bit for those people who have issues in the upper cervical. There are, we know, more exercise protocols that we can use for POTS, and then exercise for muscle strengthening is really what they need. Hopefully they can do it. That's the difficulty sometimes. Fatigue in EDS, lots of reasons why somebody might be fatigued, especially in the young, for POTS, any medicines, pain, poor obstructive sleep or sleep apnea, a secondary mitochondrial dysfunction sometimes is happening, the GI stuff, or even the median accruate ligament problems. So lots of reasons why they might not be able to get rested. And then meds, lots of meds to take, but usually Tylenol, acetaminophen is quite safe. Anti-inflammatory nonsteroidals are not safe just because of the mast cell activation capacity. And then these are other medications. I just really listed them here so that you guys have something to reference, but really this is not even in my bag of tools. I would refer to a doctor for medicines, but just that you know that some of these things can help. Anti-seizures, antidepressants sometimes help with actually the symptoms. And we're talking about helping symptoms. So tricyclic antidepressants can help with symptoms, but SSRI antidepressants don't. So this might be something that you could give to a client and they could take it to their doctor who might not be as aware. They could take medicines for muscle spasming. Epsom salts tend to actually replenish a lot of the minerals in the tissues, so it could be helpful. Sometimes an oxygen supplement for fatigue and migraines, and sometimes adrenal supplements for fatigue could be helpful. And then there's some discussion about medical marijuana. Cannabis topically does make sense for this client population. The CBD for pain can be helpful. It doesn't trigger mast cell activation like NSAIDs do. So THC might help with cognitive function. And then again, we have that antihistamine or allergy medications that could help with the mast cell activation. Another one is something called low-dose naltrexone that can sometimes help as well with lots of symptoms. So again, it's out of my bag of tools, but just information for you guys to have and pass on should you need it.
Hey, Zeina?
Yes.
I'm going to try to ask another question. You know how Andrea, you said she was trying to put herself into such a position that she went too far and moved the rib. You know how a physical therapist can hold a joint and provide resistance to a person at the same time? Is that technique good for this because you're not exerting more than the joint can support?
So if I understand the question right, my answer would be that a lot of physical therapists go wrong here because I really try not to mobilize or manipulate somebody who has EDS I try and make them do it in their body. Because if I do anything in open chain, I can set a whole chain of events off. And so the more severe EDS, and I do get some really severe ones. So the more severe ones, I really shy away from doing any manual adjusting work unless I have them participating. So what I call it more muscle energy work is what I would do. And that's what Anna, you and I do with that push-pull. But there are clients who can't even tolerate that unless it's in a closed chain position.